Where it looks like we're recording.
Yeah, sorry about that.
That's okay. Now I really have to behave. All right. So I was a Robert Wood medical student from 2012 to 2016. So I graduated in 2016, and I went to Rutgers RWJMS for orthopedic surgery, and I graduated orthopedic surgery, my orthopedic surgery residency last year. Right now I'm in Columbus, Ohio, doing a traumatology fellowship. Grant Medical Center is part of Ohio Health. It's actually the 5th busiest trauma center in the country as far as orthopedics goes. So, we get the helicopter lands pretty much every hour on the hour over here, and I live right down the street from the hospital. After this fellowship, I'm going to go over. I have a position at NYU for adult reconstruction, which is joint replacements. And then after that, I'll probably wind up setting up shop somewhere in New Jersey and practicing. So, I have a pretty good relationship with Dr. Gatt, who's the program coordinator and the department chairman of orthopedic surgery, and also Dr. Brian Cott, who I know has been involved with the orthopedic interest group, and also Dr. McPartland. I know all of them pretty well. I trained under all of them, and I've tried to stay, in pretty good touch with the medical students. I enjoy teaching, and one of the things that I remember as a medical student, especially as an M1 or an M2, was I didn't really know what each specialty kind of entailed. You have this idea, I think I might like internal medicine, or I might like peds, or I might like cardiology, or I might like surgery, but you really don't know except for what people tell you. And chances are you're only talking to your colleagues and they don't really know any more than you. And, you have to try and get in and shadow residents, or, you might have a family friend that's in a specialty, but it's kind of hard to know exactly what the day-to-day is and what the inside workings of the specialty are. So I'm going to try and, give a talk, maybe a half hour or so. I'll go over a little bit of an overview of the specialty. I'll talk about some interesting cases, my own story, and then hopefully you guys can ask some questions. Hopefully this gives you a little bit of information that'll help you along your journey. If you like orthopedics, great. If you don't like orthopedics, great. But at least this is another piece of information that you can use as far as your medical school journey. So this is basically what we're going to talk about. We'll talk about a little bit of background about orthopedics, what the specialty is, the subspecialties and what they are, my story, the application process, which I think might be a little bit useful for you guys. It's a little bit early for you to think about applying, but as a medical student, I always like to have a roadmap and kind of know what's coming down the road. That way I wasn't surprised. I can talk about a typical day in orthopedics, talk about some interesting cases, and then we'll go over questions. So as far as a disclaimer, I have some pictures of surgical procedures, and there's, you might see a patient's arm or leg or whatever. Just be professional and don't post this online. I know you guys go over, professionalism, all that stuff, so just do that. And then also, all questions are welcome. If you think I'm asking a question, just ask. Someone's probably out thinking it, or if they're not thinking it, then you're a genius. Or maybe there really is no such thing as a not good question, but we're going to find out. So, all right. So as far as orthopedics goes, there's 2 different ways to spell it. The AEDICS is the right way to spell it. So if you ever write it down, if you want to gain brownie points with your attendings, especially if you rotate with Dr. Kairos, who's a joint replacement surgeon here, you spell it AEDICS. So orthos means straight, and PAEDICS, that's Greek for child. So orthopedics actually means straight child. That's what the word means. And some of the first procedures were actually of that nature. So basically the specialty focuses on injuries and diseases of the musculoskeletal system. So bones, muscles, nerves, tendons, ligaments, and anything, and joints, anything that relates to the musculoskeletal system basically falls within the realm of orthopedics. So as far as orthopedics in general, like what are your skills that you're going to be performing on a daily basis? If you're in internal medicine, or if you're in pediatrics, or if you're in radiology, or any specialty, those specialties portend a certain type of skill. So when you're an orthopedic surgeon, you're going to be managing different pathologies, whether it be fixing fractures. You can do arthroplasty, which is reconstructing joints, replacing joints, knees, hips, shoulders, elbows, wrists, ankles, you name it. we can probably replace it. There's nerve repairs or nerve releases, carpal tunnel releases, cubital tunnel releases, or if there's a lacerated nerve that actually needs to be repaired. If you have a nerve injury, that usually falls within orthopedic surgery. Tendon or ligament repair, I'm sure at least one person here either has or knows someone that had an ACL injury and had an ACL reconstruction. So that falls within orthopedics. There is a field within orthopedics of oncology. So, bone tumors are one of the most common tumors in pediatrics. And then also it's, very prevalent in the adult population. So there's an oncological part of orthopedics. And then also, there's congenital or acquired deformity correction. People were born with limb deformities, limb-like discrepancies, angular deformities, and orthopedics works on that. And then there's also non-operative treatment. There are a lot of things that we treat medically or we treat with observation, physical therapy, physical medicine, rehabilitation. We work very close with PM&R. And then also a lot of fractures we can treat without actually cutting someone. We do things called reductions where the bone's not lined up and we actually do special maneuvers that realign the bone, and we, either put a cast or a splint on to hold it in place, and we can treat a fracture that would otherwise need to be operated on non-operatively. And then another cool thing about orthopedics is you have to also be a radiologist. So we read all of our own films. In a lot of medicine, you'll see like, oh, there was a CAT scan done or an X-ray done, and we have to wait for the radiology read to see what it shows. We read all of our own stuff. So we know how to read X-rays, CAT scans, MRIs, bone scans, and it's pretty advanced. And that's a different layer. I think it's pretty interesting to some people that we kind of handle all of that diagnostic responsibility ourselves. So those are a couple of things. So basically, some highlights of orthopedic surgery. One of the things that attracted me to it was when you treat someone in orthopedic surgery, a lot of times it's definitive treatment the day of surgery. So where that differs from like internal medicine is, say you have someone with hypertension, they come in and you do your physical exam and they're hypertensive, and you say, okay, well, I want you to take this pill. Whether it's hydrochlorothiazide or, whatever your initial treatment is. And then you like, okay, go home and I'll see you in 3 months. And then they come back and they're like, oh, well, I didn't do that. And then you have to give them a different pill, and then they don't do that. And then eventually, if the medical treatment doesn't work, eventually they need surgery, whether it's, some type of definitive correction or whatnot. But usually in orthopedic surgery, there's a problem. And when you operate on someone, they're fixed, whether it's fracture fixation, they have arthritis, you replace the joint, their nerves compressed, you release the nerve, or their ligaments torn, you reconstruct the ligament. So for instance, this is somebody that decided to cross the street without looking both ways, and he was struck by a car. And for those of you that are new at reading X-rays, I'll just help you out here. This is an X-ray, an AP, which is an anterior posterior, and a lateral of someone's leg. And this is the tibia and the fibula. So you can see, can you guys see my cursor? Okay, so if you look at the lateral over here, the bone's broken here and the fibula is broken over here. So tibia is broken, fibula is broken. On this side over here, tibia is broken and fibula is broken. So this person can't bear weight on their leg now. And I'll tell you that in order for this bone to heal, it takes about 3 months if you don't do anything, 8 weeks to 3 months. So you can put them in a cast if you want. The bone will not stay perfectly reduced, meaning like it won't stay end to end and look perfect. If you put it in the cast, it'll be close, and they'll be off that leg for about, let's say 8 to 10 weeks if you're being conservative, if they're young. So what do? We do something called an intramedullary nail. We bring them to the operating room the next day. We make an incision. Usually the incision's right up here. It's about the length of your index finger, and then we put a metal guide wire down into the tibia right over here. We put a reamer in, which is like a drill that drills a hole in the bone over here. And then we do a bunch of, we do, a little bit more complicated stuff, but eventually we insert a titanium rod that goes through the intramedullary canal, through the fracture, we line the fracture up, and then we put screws above and below. And let me see, actually, you can see over here on the lateral, the bone's lined up on the AP and lined up on the lateral. And this patient can actually bear weight that same day. So instead of them having to wait 8 to 10 weeks, we make them wait 8 to 10 hours, and then they can walk. So as far as immediate gratification, instant feedback as far as, seeing your treatment succeed I thought that was kind of cool. So that's one thing that you can do in orthopedic surgery. This is another.
Dr. Mennona, I have a quick question.
Sure.
So the intramedullary rod and the tibia, does that automatically align the fibula, or do you have to do anything surgical to correct that fracture?
Great question. So no, it doesn't automatically align it. And also the intramedullary rod doesn't automatically align the tibia either. It has to do with how you hold the bone while you're preparing it. So the fibula is mostly a non-weight bearing bone. And in these cases, a lot of times you don't need to reduce the fibula. If the fracture, and this is like way, way, way more complicated than we need to get into, but if the fracture were down here and it indicated that the syndesmotic ligaments were disrupted, then I would potentially fix the fibula. But in this case, it's mid-shaft. There's no reason to fix it. You can fix this fracture with 3 incisions, one here, and then one down here. But you wouldn't need to go after the fibula. But that's a good question. Sometimes you have to fix both bones. Like if you have a both bone forearm fracture, you need to fix both bones. But in this, you usually only need to fix the weight bearing bone. That's a good question. So this is a fracture over here. Is it Julia? Did I say your name right? Okay, awesome. So since you got to volunteer, you get to guess what happened to this guy. What do you think?
Looks like crushed by something.
Okay, crushed. That's a good guess. Now I'm gonna give you a little bit of a hint. He was involved in a drug deal that went bad. What do you think this thing is?
Is that a gunshot?
It's a bullet. That's exactly correct. It's a bullet. So on X-ray, this is these X-rays are measures of density. Oh, sorry. X-rays are measures of density. So things that are really, really dense appear very white, and things that are not very dense appear less white. So air, I'm not sure why this keeps happening over here. I'm gonna try something. Sorry, I think it's my keyboard. Air appears dark, and anything that's really dense appears white. So this guy got shot in the femur. Same kind of thing. This guy over here, I think it was a male, would not be able to bear weight on this leg for about 8 to 10 weeks. So again, another thing that we did an intramedullary nail here. So the nail goes in through the piriformis fossa. We align the fracture, and this person can bear weight. And just to show you how these were treated in the past, has anyone seen a picture like this where someone like has their leg suspended in the air, and then they have something thrown over the bed? So this is called traction, and someone would need to stay in traction for like 2 to 3 months. This patient over here was able to stay there. This patient was able to bear weight the next day, which is kind of cool. There's variability in pathology, meaning that every fracture is different. So like for those of you that like intellectual stimulation, like we're all doctors, or going to be doctors, you don't want to be bored. Every fracture is different. So this is a femur fracture, very different from the femur fracture that I saw you, but it's distal, meaning farther away from the center of the body. It's a distal femur fracture. And it turns out that this person has a total hip replacement above it, right over here. So this, and let me see if I can show you the CAT scan over here. I think I have it over here. Yeah. So this is a CAT scan, and I'll just help you as you go through it. What this shows, you're looking at an image. You're looking at the body being sliced in an axial configuration, but basically this is the kneecap. This is one end of the condyle. This is the other end of the condyle, the medial and lateral condyle. What that's showing is a split right down the middle of the joint. So what you have to do when you look at this is you have to figure out, all right, where are the fracture lines and how am I going to treat this? And on this over here, you're looking at coronal, which is basically an AP of the knee. And you can see that there's a fracture going right down the middle, right over here. And you can see the shaft is displaced right over there as well. So basically what we're looking at as orthopedic surgeons is how exactly am I going to fix each of these fractures? What incision am I going to use? What approach am I going to use? How am I going to move the muscles around? How am I going to move the nerves around to not injure them? And, do as good a job as possible. And that's different for every case. So every case that we do, we come in and we take a look and we're like, all right, what's my approach? What's my plan? It's not like mindless. Effective surgery. So that's also what's really cool about this. So does anyone want to take a guess and say what this implant is and what the purpose is?
So total hip replacement.
That's exactly. It's a total hip replacement. So this person probably had arthritis, and I will tell you that I've seen patients that have had debilitating pain, and they come in, they can't walk, they can't put their socks on, they can't get into the car, and we do a total hip replacement on them. And they come into the office and they're crying. I'm talking like grown men in their 60s are crying because they're so happy that you give them their life back. And that's a really good feeling. And I think it doesn't always happen in medicine. A lot of medicine's underappreciated, and that's a different story. But have any of you guys ever heard of the Lancet journal? Okay, so there's like the New England Journal of Medicine and there's the Lancet, right? So the Lancet wrote this article back about 10, 15 years ago or 13 years ago. And the name of the article was The Operation of the Century, the total hip replacement. Now, obviously there's a lot of technical nuances to doing total hip replacement, but if you do it well, it's like a 96 to 98% satisfaction rating. So you feel pretty good doing that. And then also for those of you that are math people, there's a frequent use of math, chemistry, and physics. When we use different types of implants for different types of goals. This is a distal radius fracture, meaning a wrist fracture, and that's a distal radius plate. This plate is made of stainless steel. The nail that I showed you for that guy's femur is made of titanium. And you would ask, why do we use these different types of materials? It's because that certain materials bend a little bit different. We're very familiar with something called the Young's modulus of elasticity. We know where bone is. We know that titanium is the closest metal that we have to bone. Stainless steel is a bit harder and a little bit more brittle. But we use each of these as far as their physical properties. There's a lot of physics. We use load bearing or load sharing material constructs depending on the fracture. So there's a lot of intellectual stimulation there. And then this is something that we use called tantalum metal, which is a highly porous coated metal that's a very, very sophisticated chemical reaction. Actually, their plant is in northern New Jersey, and it's not Mawa, but I forget where it is. But basically, this metal is designed for bone to grow into it. And all of our joint replacement prostheses, a lot of them are now coated with this. And it's incredibly complex. It's incredibly interesting. But there have been a lot of advances that have allowed people to have joint replacements that last, decades. And then also there's deformity correction, which is very interesting. So if you look over here on the right, this is someone that has an old fracture that was not treated with an intramedullary nail. This was treated probably in a third world country. It didn't go well. And you can obviously see that your tibia is not supposed to be treated that way. So what an orthopedist would do is put this type of instrument on. It's called an Alizarov frame. And there's a lot of preoperative planning. We use very complicated, but also at the same time, easy to use computer programs. We use trigonometry and some calculus, and using these measurements and figuring out how to space this out as far as the biology, allowing the bone to heal, and slowly deforming and correcting that bone, you can achieve. This doesn't look like a normal tibia, but it looks a heck of a lot better than the other one does. So that's pretty gratifying as well. And then also we use state-of-the-art technology. So I'll show you, this is a video of me in the operating room. And what this is called stealth navigation. And right now I'm putting screws into someone's pelvis. This person got hit by a car and their pelvis was fractured, and also all the ligaments were torn. So I'm putting a screw that's about the width of your finger through a corridor, trying not to hit any nerves. You have about 2 millimeters of clearance on either side. And you're doing it blind. You're using CAT scan, but you can't actually see into the pelvis. So I'll show you. So you can see over here, you can see the yellow, you can see this little yellow cursor moving. And that's my attending right there. He's going to drill while I'm actually showing the trajectory of my screw going into the pelvis. And then I'll show you over here, actually, this is me putting a screw all the way across the pelvis here. So it's going from one side of the pelvis to the other. You can see that as I move my sensor, you can see the CT scan moves in real time, which is kind of cool. And this is recently developed in the last couple of years. And that's them pulling a trauma while we're doing it. But doing this, let's see if I can skip to the next one. And then once we put our screws in, this is actually a mobile CT scanner that comes in and actually scans the screws to see to make sure they're in the right place. Because if you put it the wrong way, I'm sure you can imagine there's important stuff around your pelvis that if you hit it, things go pretty bad. So we use real-time CT scanners to basically 3D navigate screws into the pelvis or into the acetabular, which is pretty cool. So that's like, very high-tech stuff. That machine that I was using was probably several $1 million. They have that at Robert Wood too. There's usually like one per trauma center at a level 1. So it's pretty cool stuff. Different orthopedic subspecialties. General orthopedics, that's usually after 5 years of residency, you're considered a general orthopedic surgeon. There's orthopedic pediatrics, foot and ankle surgery, oncology, traumatology, which is one of the fellowships I'm doing, and then adult reconstruction, which is joint replacement. That's also another one I'm doing. Hand surgery, shoulder and elbow, and then spine. So just a couple of like examples of cases that you do. So pediatrics, I tried to figure out cool cases that would be, appealing. One of them is adolescent or congenital scoliosis correction. So I don't know if any of you guys were told that you had a curved spine when you were younger or not. And some of you actually may have had surgery, but I'll show you a picture of what that looks like. But that's something a pediatric orthopedics takes care of. Foot and ankle does congenital foot deformities, some trauma, musculoskeletal oncology. There's very advanced techniques for limb salvage, whereas, in the past, if someone had a bone tumor, you did an amputation, but they have like very sophisticated techniques now for that. And sometimes you still do need to save a life by taking out a bone and potentially amputating the limb, but it's very, it's a very gratifying, but also very complex field. Traumatology, we kind of specialize in complex periarticular fracture fixation. So fractures around joints and the acetabulum and the pelvis, where there's a lot of, bad things that can happen. Where like, if you cut the wrong artery, someone can die pretty quick. So we kind of specialize in acetabulum and pelvic fractures. Adult reconstruction is joint replacements. Hand surgery is basically anything from the wrist up. They're pretty much experts in. So carpal tunnel releases, wrist instability correction, distal radius fractures. Your shoulder and elbow surgeons are very good at rotator cuff repairs, whether those be open or we can stick very small cameras into the joints. They're called arthroscopy arthroscopic scopes, where you can actually use a camera and you can do an entire surgery through an incision like this big, like 2 or 3 of them, which is pretty cool. And then spine surgery, you can do correction or fracture fixation. So this is a picture on the left here. This is someone that has a scoliotic curve. So you can see that the spine is kind of curving like this. Then we have classification systems and we can measure angles and whatnot, but this person met operative criteria. So this is a posterior spinal instrumented fusion, and the quality of life of this patient is probably greatly increased. Number one, their physical appearance, and then also probably like their mental health as well. And then this curve, if it's not treated, will continue to progress to actually threatening levels as far as the patient, because of their scoliosis curve, won't be able to breathe. The functional capacity of your thorax will decrease because basically your lungs can't expand the way that they're supposed to. So this is like a life-saving surgery in the long run, which is pretty cool. So that's peds. This is basically a cool case from trauma. This was someone that I think they slipped and fell on the ice. It was like a 50-something-year-old that was ice skating. And you could see he has a segmental fracture, meaning he has a fracture here, and then he has a fracture there, and then he has a fracture going through the joint. So this is in 4 different pieces. And what you can't see is he actually has a plate above that because someone operated on his shoulder in the past. So this was something that I did the other day. So this guy had this plate was here before, but basically what we had to figure out was, what type of approach do you want to take? Because on this side of his arm, he has his ulnar nerve, and that's the nerve that if you bang your funny bone hurts like an SOB. On this side of his arm, he has his radial nerve, which is everything that extends your wrist. Did you guys have anatomy yet?
Some of the M1s, we didn't cover musculoskeletal stuff yet. We just did
Okay. All right. So there's a lot of nerves and arteries. And so when you guys do musculoskeletal, you'll understand that a little bit better. But basically we had to figure out how to get around all the dangerous stuff and put all these plates on. And this guy's able to move his arm the next day, which is pretty cool. This is someone that has a wrist fracture that I operated on. I did this guy today. I operated on this guy a couple hours ago. So this is a wrist fracture fixation. So you can see over here that the fracture is right here. And then there's also a fracture going up that way. And then this is a lateral, and you can see the wrist is angulated back about 40 degrees. And then if you look at this over here, everything's corrected. So the plate is sitting right below the joint, which is right over here. And then the plate sits here, and this plate will sit here forever, as long as it doesn't get infected or it doesn't bother the patient, which is very, very rare. And this procedure takes about 45 minutes. So just a little bit about the journey of orthopedics. So most programs are built, it's a 5-year residency. Usually your first year is 6 months of general surgery. You do like trauma or vascular or maybe plastics. It depends on the place. And then you do 6 months of orthopedics, and then your other 4 years are orthopedics. And then you rotate usually within those specialties that I talked about. And then there's usually a fellowship that you'll do. So it's 6 years total. You don't have to do a fellowship. I would say in the Midwest, it's more common to have a general orthopedist that's not fellowship trained, but on the East Coast and on the West Coast, it tends to be that if you want to have a competitive job, usually you'll do a fellowship. And there are some rare, and most of the fellowships are 1 year. There are some rare exceptions. There are some 6-month fellowships, and there are those that are a little bit different. But for the most part, everything that I showed you is 1 year. And then, the application process. So, just like general advice, one of the things that I've, heard a lot is, do you study for your exams or do you study for step one? I think you should do both. Don't, like, a lot of people, well, it used to be that step one was a very important test because it was a numerical score, and it was kind of an equalizer after you had your pass fail years, but it sounds like step one is pass fail for you guys now. So I don't know exactly what your evaluations are going to be comprised of as far as your first 2 years. I will tell you that step two is still numerical. So I think step two will get more important, especially for a field like orthopedics. So, I think that it's smart to get as good of a foundation as you possibly can in your preclinical years. I know you guys have all your study aids. Do you still use Golion and Pathoma?
Yeah, we have Pathoma, first aid, boards and beyond, etc.
Boards and beyond, yeah, okay. I'm trying to remember what I had. But in any case, there's always good study aids. You can use those, but also also enjoy medical school. Like, enjoy the stuff that you're going to learn. I will tell you that, my field is very focused, orthopedic, general orthopedics, but I was just on the phone with one of my family members, and they were asking me about urology stuff. And you can't just be like, no, that's not my job because it's your family member. You have to answer questions. Or my sister's pregnant. She's like 4 months pregnant. And she's asking me about what the baby's developing and what's moving and what's not. And, you have to, you're always a doctor. So just enjoy the stuff that you learn. And a lot of stuff like OB and peds and cardio, you don't have any more training than you do in medical school, because once you start to specialize, that's your training. But I will tell you that I speak with cardiologists on a daily basis, and I do speak with trauma, like general surgery, on a daily basis. And once in a while, I operated on a woman that had an acetabulum fracture that was in her second trimester, and it's complicated, and you have to kind of reach back and say, all right, what do I remember from medical school? Because it is the base of what you do. So, so factors, like I said, this is based on the past, but your USMLE step one sounds like it. I mean, if you fail step one, then, you got to fix that. But so pass step one, do as well as you can on step two, because the numerical score does help. Your shelf exams, your class rank. So usually what will happen is when you go to apply for away rotations and whatnot, there's this dean's letter they write a letter for you. It's a recommendation letter. And usually the way it used to work for us was there was like an indicator word. So it would say like, you know, Steve Mennona is a very good medical student. Steve Mennona is an excellent medical student. Steve Mennona is an outstanding medical student. And usually that word signifies where you are as far as your relative class position. And it's not like, you know, I think there's some variability to it. Like if you're a very good student, you should have a very good indicator, and it's not something I would stress out about, but those things do kind of come into play. Your letters of recommendation. So, you know, if you have a good relationship with someone in orthopedics and they know you well, that's good. But if there's also someone that's not in orthopedics and they know you well, I think that matters more than just someone you met like, you know, on an away rotation, or you met them for like 2 weeks and ask them to write a letter for you, because they can't really write a great letter. I mean, they can, but you know, it's hard to get to know someone. So if you know, if you have a good mentor and they know you well, I think that's important. But that's, you know, that's kind of down the road for you guys. Away rotation. So when you're a PG or when you're an M4, you'll have the opportunity to go to some hospitals and spend some time there and rotate and, like, you know, observe and help and take call with the residents. And what I would tell you is that when this happens, maybe think about like a place that you would like to go. Like say you're like, oh, I would love to explore the West Coast and I think I might want to do residency out there. Then go rotate on the West Coast. If you don't want to go on the rest, if you want to stay on the East Coast, then don't do an away rotation there. If you have, say you're married and you want to do the couples match, if you and your significant other rotate at the same hospital, it'll help, and things like that. So away rotations do help, though. A lot of programs, if you rotate there and you do well, they, like, when they're looking at your application, they have a face, and they, you know, it actually goes a lot farther than you would think. And then the last thing is persistence. So orthopedics is competitive. I'm not going to sugarcoat it. Like it's not a field that you just walk into, but it's not impossible by any means. And it's definitely a field that if you want to do it, you can. It may not work out the way you want, as far as, like, you know, say you're, you know, you meet with your advisor and they say, hey, you know, you're kind of a borderline applicant. Because you have to remember, like, being a competitive applicant for a field, you're among the best and the brightest people in the country. You're in medical school. Like, it's not, you're separated by like the thinnest of margins. So sometimes it's a little bit of extra persistence, whether it's doing more research or, you know, some people take a year off and they will go to a certain institution and do research there, or they'll shadow there and whatnot. And then the people get to know you and they see that you're a good person and a hard worker, and then that's your way in. So there's no right or wrong way to do it, but those are, you know, different things. So just, again, like I said, just a little bit about me, just to show you I'm not a robot. I was born and raised in New Jersey. I went to Fordham University in the Bronx. So I graduated in 2012. I didn't take any time off. I went right to medical school. I did orthopedic surgery. So that was 5 years. And then I'm doing 2 fellowships. So I'll be done in 2023. Why did I pick my field? The general answer, what I told everyone when I was interviewing, when I interviewed with Dr. Terragino, I told her I wanted to help people and she let me in. So that was cool. Thanks, Dr. Terragino. Why did I do traumatology? Basically, you know, I think everyone is someone's son or someone's daughter, right? And a lot of times in trauma, people come in and they're having basically the worst day of their life. And someone needs to be there to help them. And I think it's a privilege to be able to help someone when they're at their most vulnerable and when they're in that time of need. And, you know, it is stressful sometimes and it is taxing. Like I just put in a 13-hour day today, and I'm going to do the same thing tomorrow and the same thing the next day. And you do get some time off, but it can be taxing on your mind, on your body, on your soul. But at the same time, you know, I think it's very gratifying and it's a special thing. So that's why I picked trauma. And then also trauma itself, there's a lot of problem solving. It's very hands-on. Every fracture is different. You saw how cool the technology is. And then usually at the end of it, you fixed it and it's done. And then as far as arthroplasty, you know, when you replace someone's joint, usually you improve their quality of life. And then why did I pick both? There's you know, there are some very complex reconstructions in the pelvis doing joint replacement. I'll show you later that both actually help. And then some of training, one of my mentors, Dr. Kairos, has a trauma and joint background, and he's one of the most gifted surgeons that I've ever met. And Dr. Sahabian, who's also at Robert Wood, is one of the best trauma surgeons in the country. So both of those guys kind of inspired me to follow those fields. So some cool trauma stuff. This is someone that was, what did this guy do? Oh yeah, he was driving like 80 miles an hour and then hit a pole, and he went to go brake, and obviously the brake, his foot going into the brake was an incredible amount of tremendous force. So he has something called the subtalar fracture dislocation, meaning this is if you look over here, this is his tibia. His ankle joint is right over here, and then the talus is what your tibia sits on top of, and that you could see is extruded outside of the skin. The skin's right here. And then that over here is the clinical image. Over here, this is him up in the operating room. This is his posterior tibialis tendon. So it's kind of caught underneath the bone there. And I reduced him, washed him out. And then that looks like an actual normal ankle X-ray now. And this is an external fixator, which kind of looks like the Alizarov that we put on. And then these are Steinman pins going and holding his ankle in place. And he did pretty well. This person over here, I'll just show you, I think they were involved in a car accident. And you can see over here, this is a pelvis X-ray, and you can see how this side of the pelvis does not look like this side of the pelvis, just to, keep it pretty simple. But what happened was this person's knee went into the dashboard, and then the force went up and through the acetabulum, which is the hip socket. And you can see that the hip joint has moved into the pelvis, basically. So this is called a both column acetabular fracture. And you can see over here, this is a coronal CAT scan. You can see that the joint over here is supposed to be over here. So it's moved into the pelvis. And then you can see over here, this is an axial. So looking down at the pelvis, like you're standing over someone, and you can see how the acetabulum's been split in half, right? Like this part and this part are supposed to be one. And then on this side over here, this is looking at it from the side, you can see the split down the middle. I tried to pick like images that are kind of like telling. So this is what we did. So we made an incision basically underneath his belly button. It's called a fan and steel incision. And you dissect down, and we put a plate basically from all the way, this is the iliac wing over here. So that's like your hip bone. And we put a plate basically all the way down on the brim of the true and false pelvis. And then these are screws holding together the actual iliac wing. And then right over here, so talking about like trauma surgery and why it's complicated, right over here, there's a leash of vessels called your corona mortis, and it's the anastomosis of your external iliac blood system and your obturator blood system. And if you cut that anastomosis, someone can bleed to death in minutes. So you have to be pretty careful of that. But once you get that out of the way, you can take care of this. So this patient did pretty well. But that's called an acetabulum open reduction internal fixation. And then this is actually,
sorry, a quick question. So for cases like that, do you usually have a vascular surgeon that you're consulting with, or
not unless something goes wrong.
Yeah.
Usually you put a Foley in because you're right on top of the bladder. And then if you cut the corona mortis, which you're not supposed to, that's why you do a trauma fellowship. But if you get into trouble, then yeah, you need to call vascular, and they'll come in and they'll help you if you can't control it yourself. But it's not something that you want to do, but it's a danger. There's a lot of dangers when you do acetabulum surgery, but that's one of the things. This was a case report actually that I wrote up with Dr. Kairos and Andrzej Brzezinski, who's a chief resident over at Robert Wood right now. And this is one of those things that's like a complex case of that's trauma and joint related. So kind of similar to, if you look over here, this is a deformity called protrusio, meaning the hip is going up in medial where it's not supposed to. So kind of take a mental snapshot in your head of what that X-ray looks like, and then look at that. So this lady has a total hip replacement, and she has an infection. She actually had a dental procedure, and that seeded her blood and caused her her total hip to get infected. And this is called a Popovsky 3B defect. Basically, her hip is up in her pelvis. And you guys didn't take micro yet, did you? You did. Okay. I saw someone nodding their head. So what do bacteria form on non-organic surfaces that make it harder to kill them?
Biofilm.
Biofilms.
Biofilms. Yeah, exactly. So they do the same thing in the body. So bacteria form biofilms, especially on the metal thing that you put in. Antibiotics won't kill it. So the only way to actually get rid of an infected joint is you have to rip the whole thing out. And when I say rip, I don't mean like actually rip, like you have to delicately surgically remove it. But this whole thing has to come out. And you could see you can appreciate how big it is. It's going halfway down her femur. And if you look down here, I just moved the thing over here. So if you look down here, she had an abscess that was basically half the size of her pelvis. And you can see this abscess from her infection basically eroded half of her pelvis, and her hip is basically floating in the middle of her pelvis, which is not good. So what did we do?
Are there any joint replacement like hardware that have been designed to kind of avoid that process of biofilm formation or lessen the effects of it?
Yeah, so the answer is no. And it's not, so bacteria will form a biofilm on anything that you put in the body. So what we do sometimes so joint replacement surgeons are like super concerned about sterility. Every surgeon is, but if a joint gets infected, it's a disaster. It's a really big problem, and it's a multi-billion-dollar problem as far as the healthcare system. What we can do sometimes, if someone has an infected, like if they're high risk for infection and they need some type of joint replacement, either we'll have them wait until they clear the infection, or if it's like a fracture, or they're like, when you take this, like this lady, when you take her hip out, like what's she gonna walk on? She can't walk because like she has nothing left. So you can put prostheses that are surrounded by antibiotic laden cement. So we'll put cement around it that are impregnated with like vancomycin or gentamicin, and they elute antibiotics, and that can help. But the truth of the matter is it's very, very, very difficult. And whoever invents a joint that can't be seated by biofilm is going to be living on a beach and pretty much, not doing anything for the rest of their life. It's a very big problem. And there's a lot of research in it. But this lady over here, so she underwent a lot of medical treatment, consulting with infectious disease, and we did basically a reconstruction of her pelvis. We reconstructed like the whole right half of her pelvis and put like a huge cup and cage in, screws going into all different parts of the pelvis. And this is one of the close cases that I was part of. And Dr. Kairos is an absolute animal. Like I said, one of the smartest guys, one of the most gifted surgeons that I ever worked with. But what's cool though is this lady had like a devastating infection. Her hip had to come out, and most people would say like, you're never going to walk again. And she showed up in the office the other day. I talked to Dr. Kairos, and she was like walking with a cane, and she's like the sweetest lady. She lives alone. I think she's like in her 70s, but like she has like a little dog, and she can like, walk the dog, and it's cool, so that makes you feel a little bit better. This is a cool
proximal femoral replacement.
Yes, it is.
Stage.
Yeah, so this is a proximal femoral replacement.
Mhm.
And then this is something called a custom 3D printed triphalange cage. The reason we call it a proximal femoral replacement is her greater and lesser trochanters are replaced by this mega prosthesis. So if this gets infected, she's in big trouble. Let me see, what was this? Oh yeah, this is cool. So this is a 3D reconstruction of someone that had a proximal humerus fracture. So I'll just play that for you. So this is the scapula. This is the humeral head, and you can see that's all smashed. I forget what happened to this guy. I think probably another car accident. We see a lot of high energy trauma. Basically, his humeral head is absolutely destroyed. It's not going to heal. You could see basically this is supposed to be like a light bulb looking thing, and you could see that it's just not. It's irregularly shaped. It's a 4-part proximal humerus fracture, and it's really not something that's amenable to screws. So what we do, and this person actually decided to leave and come back 2 months later. So his you could see over here, that does not look like a ball. It's bad. So what do? You tell him to live with pain for the rest of his life? You really can't do that. I mean, you can, but that's not nice. So we did something called a reverse total shoulder replacement. So this guy has no rotator cuff, And this type of prosthesis actually, usually the ball's over here, and then the socket type thing, which is the glenoid, is over here. But on a total shoulder replacement, you use the body's anatomy. You use the deltoid instead of the rotator cuff for arm motion, and you switch out the concavity and convexity, where your glenoid becomes a ball and your humeral head becomes a convex surface. And this was something that we did that was pretty cool. And so that's it. So actually, it was a little bit longer than a half hour. Sorry about that, but that's kind of the overview of orthopedics, specifically trauma. But I can answer any questions you guys have, and whatever kind of comes to mind.
Well, I just want to start off by saying thank you so much for having this incredibly informative talk. So yeah, like Dr. Mennona said, we're going to open the floor. Don't be shy. No stupid questions.
Yeah, I had a question about bone grafts. Where is that usually taken from? Is it usually more like non-weight bearing portions, or kind of how does that work in terms of selecting? Well,
Sure, that's a good question. So bone grafting, usually the reason we'll bone graft something is we're trying to help it heal. So bone itself will heal, but only up to a certain point. And there's different types of bone grafting that you can do. There's bone grafting that provides a structural scaffold for bone to grow. That's called osteoconductive. So what we'll do is we actually can take a cadaver and crush up their bone after it's been radiated and freeze dried. And you can put that in the body, and then your osteocytes will kind of use that as, it's like moving into a house that's already built for you. There's osteoinductive things like bone morphogenic protein or stem cells, and then there's osteogenic, where you actually transplant bone itself, like bone marrow. Where do we take it from? Some common sites are like the iliac crest. You can take it from the greater trochanter. You can actually send a reamer up and down the femur and take out basically your reamings, the inside of the femur, not the cortex, but the medullary, the intramedullary canal contents can be used as bone graft. So it kind of depends on what you're trying to do. And also, like, why are you doing it? Are you using it for someone that hasn't healed, called like a non-union? Are you doing it for someone that has like a bone defect? Is it someone that, you're trying to acutely increase their chances of healing? So there's different indications for it.
okay, thank you.
No, you're welcome.
So I had a question. So I know you mentioned usually, with the orthopedic residency, you kind of learn everything, and then you went to fellowship to kind of specialize. Sorry, I didn't realize my camera was off.
That's okay.
So I was wondering if, let's say, you wanted to go into trauma, but you didn't want to specialize into like something else like joints. Can you specialize in like lower extremity trauma, upper extremity trauma, or do you just do everything?
Yeah, well, so it's not common to do two fellowships. Most, I would say 90%, 95% of orthopedic surgeons either do one specialty or none. It's not the majority that do two. And then what you guys also, you'll learn, when you went to high school, like there was a right and a wrong answer. Like the right answer is to take the hard class, like the AP classes, and the same thing in college. And then, but like once you get to medical school, there's not really a right or wrong way of doing things. Like if you want to go into a certain specialty, it's not wrong or right. It's just what's best for you, because you have to pick your career, right? So like say you do your psych rotation and you absolutely fall in love with it, then that's the right answer for you, but it might not be the right answer for the person next to you, because that's not their personality. It's not what they like. And the same thing when it comes to like when you get into orthopedics, it's like, well, what specialty do I want to do? You can do pediatrics, and then you could say, hey, like I don't want to do scoliosis. I want to do limb correction deformities. And Robert Wood actually has a pretty good track record. Almost a lot of our residents go into peds, and like one of my buddies, John, who was my classmate, John Ghazi, he's actually probably going to come back as a pediatric orthopedist to Robert Wood. Or at least I think he is. That's my theory. But I think will do a lot of scoliosis stuff, and I think he'll do a lot of pediatric hip deformity, but I don't think he's someone that would do heavy pediatric trauma, or he may not do like upper extremity deformity correction or lower extremity deformity correction, whereas someone like Dr. McPartland might, you know. So you can kind of specialize the way you want. And like within trauma, you know, it tends to be that some people tend to gravitate towards certain things. Like some guys are very, like, they love doing pelvis surgery, they love doing acetabular pelvis surgery. Some people really like lower extremity, like you said. Some people really like upper extremity. And you know, me personally, I like nailing things. That's why I showed a lot of nails. And I like periarticular stuff. So I mean, we'll kind of see. But yeah, you can do whatever you want. And you know, part of it, you have to think about like what you want your lifestyle to be. Do you have a family? Do you want to be someone that's on call and going in and operating in the middle of the night, or someone that wants like a 9-to-5 job? There's no right or wrong way to do it. It's just kind of like how you see yourself.
Thank you. And just to follow up, since you mentioned like the whole work-life balance sort of thing, what worked for you when you were trying to when you were first starting and you were trying to adjust to like the high pace spontaneity of trauma fellowship? Because I know that you're on call and like things just happen that you just got to spring into action. So
so I will tell you that orthopedic trauma itself, there are high pressure situations and there are long hours, but also a lot of places now, especially like a level 1 center like Robert Wood, they have a room every day that's dedicated to orthopedic trauma. So your lifestyle is actually not that bad. The amount of times that you have to come in the middle of the night are a little bit more rare, whereas it was a lot more frequent back before they had these dedicated rooms. But we know from our literature, a lot of times like an open fracture where the bone's sticking out, as long as the patient gets antibiotics and they go to the OR within 12 to 24 hours, it's okay. So if they come into the trauma bay at 2:00 in the morning, it's not the end of the world if they go to the OR at 7 in the morning. And your lifestyle is a lot better if you can come in at 7 in the morning and operate as opposed to 2 in the morning. Some things can't wait, obviously, and that's why you're on call and there you have the ability to come in and operate, in a very short time period. But the lifestyle is definitely better than it was like 20, 30 years ago.
Well, that's good to know.
Yeah.
At what point did you realize? Oh, I'm sorry. No, go ahead.
Okay, yeah, I just had a quick question in terms of like the process for you applying for a fellowship, and especially like the 2 fellowships that you're doing. Could you just kind of walk us through a little bit of that in terms of, were you applying during residency for both of those fellowships, or as you started the current trauma fellowship you're in, did you also then apply to the NYU program?
Sure, yeah. So when you're a fellow or when you're a resident in orthopedics, you apply a year in advance, if that makes any sense. So your PGY 4-year, you apply for your 6th year of training. So like you apply for your fellowship like in the beginning of or the middle of your 4th year, and then you find out at the end of your 4th year, you go through your 5th year, and then you do your 6th year of training. So what I did, I kind of had a plan to do both. So I applied my 4th year for my 6th year of training, and then I applied as a chief resident as a 5 for my 7th year, which is my NYU fellowship. So I kind of knew. And like some people, I mean, it's not unheard of. Like some people will do a fellowship, go out and practice, and decide they want to do something else and come back and do another one. It's kind of rare, but you can also do that if you wanted to. The thing is though, when you are a fellow, you make money, like you make X amount of dollars as a resident. When you go into fellowship, you either make about the same amount or even less for whatever reason. Sometimes fellows get paid less. And then like once you become an attending, you make an attending salary. So it's, I think a lot of people don't want to go back to making what a fellow does, especially by that time, like, you may have a family, or you may have a house or financial obligations and things. So it's a little bit harder to do that. But yeah, I planned it out and I did it like sequentially. So it was like one right after the other, but like, again, there's no right or wrong way to do it.
Okay, thank you. Just a quick follow-up. In terms of like the competitiveness of those type of programs, I know maybe there's 1, 2, 3, or 4, slots. So a little bit, smaller than maybe like a residency, position. So like, what are some things that you would suggest students who are, in their PGY 4 year, or how you did in your chief year, do to prepare themselves to apply for those fellowships?
Oh, for the fellowships? Well, that's very well down the road for you guys, but I would say that once you become a resident, I think you have to find out what you like. And then orthopedics is a pretty small field. So a lot of people know a lot of people. And if you gravitate towards a certain subspecialty, find a mentor. And then once you find that mentor, kind of tell them that you're looking to do that subspecialty. And fellowship's a lot different than residency, and it's a lot different than medical. In medical school, you're saying, please, please, please take me. Please take me. And in residency, a lot of times you're saying, like, please take me. When you get to fellowship, it's a lot different. Like, it's more like, is this the right fit for you? You're matching into fellowship in orthopedics is not like matching into orthopedic residency. When I matched, I think it was a 67 or 68% match rate. So if you think about it, like 1 in 3 people don't make it, which is pretty tough. But when you go for fellowship, it's, your match rates like in the 90s, I think. So it's very different. So there's like this bottleneck. But yeah, you just kind of have to figure out what you want. And a lot of it's more letters of recommendation and who knows who. And, you wind up where you're supposed to once you get in. Getting in is the hard part, I think. Julie, I think you had a question.
Yeah, I was kind of wondering, like, what are the considerations for using hardware in children or like people who are still growing? Like, would you use an intramedullary rod for someone who still has a few growth years on them, or does that kind of change what you decide to use and how you decide to fix fractures?
Yeah, we just tell them tough luck. No, I'm just kidding. Yeah, so no, that's a very good question, and that's one of the things that you're trained in orthopedics. So say someone has that distal femur fracture that I showed you. Let me see if I can go back. Okay, 1 second. Okay, so this one. All right, so say a kid had a fracture, and the kid wouldn't have a total hip replacement. I mean, they might, but if a kid had this fracture, we would mostly call it a Salter-Harris 2 fracture of the distal femur. And what we would do normally, we treat fractures. We treat fractures in kids sometimes differently than we do adults. So, for instance, that wrist fracture that I showed you, the distal radius plate, if that same fracture had happened in a kid, we wouldn't operate on it. We would just put it into a cast and it would heal. And if it were a young kid, or a young child, I'm sorry, even if it wasn't perfectly lined up in the cast, after a year of growing, it would be perfect. The pediatric musculoskeletal system has an incredible ability to regenerate and to correct deformity. But when it does need fixation, yes, we do consider the physeal status, whether their growth plates are open or not. In some cases, you have to kind of pick the lesser of two evils. In some cases, the damage is done to the growth plate from the injury itself, and then we have things called growth arrests, and that's another thing. That's another field within pediatric orthopedics. So, if, say we had someone I think I operated on that crawled underneath a lawnmower when they were 5 or 6 and had like a very bad injury to their leg. And as a result of that injury, their leg had a growth arrest that happened when they were like, 6. So what that patient had a series of surgeries to try and correct the leg length discrepancy. And that was a combination of stopping growth on the other side of the leg and lengthening the leg and using bone transport, and that Alizarov frame that I showed you. And it gets very complicated. And there's a lot of intellectual exercise that happens with that. But yeah, no, it's definitely a very prevalent field in pediatric orthopedics. And We try to, I would say we probably instrument pediatric patients less, but we also have different implements. Like we have flexible nails as opposed to intramedullary nails. We have temporary type of fixation. Some things you don't have to operate on if you don't, like if you break your radius in your ulna as an adult, it has to be operated on. Because if you don't, then you won't be able to do this. If you break that same bone in the same exact way and you're 10 years old, we put you in a short arm cast and you can move it in 6 weeks. It's very different.
Thank you.
Hi, Dr. Mennona. I just had a quick question about your the tibial fractures in the beginning. So I saw that there was a couple fractures, and I just wasn't really clear on like when you put in the IM nail, when you have multiple fractures like that, where you have fragments kind of floating out of space, is that something that you take into consideration, or do you just like rely on resorption of those fragments and then like
You talking about this guy over here? This one over here?
Yeah. So this fragment specifically. So like I understand that the IM nail is going to give it integrity and that you're going to be able to like function on that leg pretty quickly. But I was just curious, like, does that bone fragment pose any kind of like risk for injuring the muscle, any kind of neurovascular bundles, or do you just rely on the eventual resorption of that fragment?
Yeah, so that's a good question. So we would call this comminuted, meaning there's multiple bone fragments. And the principle basically in this fracture is to restore length, alignment, and rotation. So when you put a nail down this person's femur, the 3 things that you want to happen at the end of the case are A, you want the femur to be the same length as the other femur. You don't want it being shorter or longer. The second thing that you want it to do is you want it to be as straight as the other femur. And then the last thing that you can do, if you can kind of think about it, is like, say you don't see this screw over here and you don't see this screw over here, and you just had a rod going down. You can imagine in your mind's eye that the distal or the far part of the leg can rotate relative to this. There's nothing stopping it. Does that make sense? So you don't want to have this leg grossly externally or internally rotated relative to the other one. So those are your 3 main goals. Once you have those 3 main things ironed out, the fragment right over here and the fragment over here, someone asked about bone graft before. It's actually great to have those there. They won't resorb, but what they'll do is they'll actually be a biological catalyst for healing. Because on the inside of these fractures over here, there's a number of inflammatory markers, interleukins, cytokines, all of your macrophages, neutrophils, all these things are growth factors, are all being activated by the endothelial injury. And it causes an incredible response as far as healing goes. So leaving those things there is actually okay. And then the other question that I know may come up is, do we go after the bullet? The answer is no. Not unless it's in the joint, meaning like it'll erode a joint away, or if there's like a vascular injury and it needs to come out. That'll stay there, it'll get encased, and it may work its way out or it may not, but there's no reason to go after that. And I will tell you that the femoral artery is right there. So if you start dissecting around that bullet looking for it just so you can drop it and give it, to law enforcement or whatever, you can like seriously injure someone. So does anyone know what primum non nocere means in Latin? Primum non nocere means first do no harm. So, don't go after the bullet just because you want the bullet, because you can like hurt somebody. So that bullet will stay there.
And then, so thank you for explaining that. And then I also have a follow-up, and I don't know if this is a little bit technical, but I've seen a couple of like IM nail cases, and I've noticed that in some patients, the top nail that you see at the top of like the femoral head is angled downwards, but in some cases it's angled upwards. I was just wondering like if that makes a significant difference, or if you would have like special considerations in which way you put in that top nail.
Sure. So that's actually a screw. So what I would say, so this is whether you put your cephalomedullary fixation, meaning screws, or in some cases helical blades that go up into the head, the main reason for doing that would be whether or not you're either fixing or prophylacting the femoral neck. So this is a direct blow, like there was a gunshot that caused the femur to break, but a lot of times it's a high energy injury, meaning that it's like, a motor vehicle or a motorcycle or a pedestrian struck. It takes an incredible amount of force to break your femur. It's a very, very, very tough bone. So a lot of times that energy either travels up your femur or travels laterally, but like you can kind of imagine a lot of times someone's in the car and it's a deceleration injury where the knee or the distal part of the leg impacts something and then it causes the femur to break, or there's a rotational injury. And a lot of times the femur will break at one point, but then it'll also break up here. So a lot of times putting a cephalomedullary fixation going that way will also aid in that. Or the other case is the fracture is not here, but it's up higher, and to gain better rotational control, we'll put something up into the head. So it kind of depends on the case, but usually a cephalomedullary pin or a cephalomedullary blade or cephalomedullary screw, whatever you want to call it, those are the reasons for it. This is just a standard femoral nail. It's a piriformis entry nail. This is a greater or lesser trochanter screw, and then this is a dynamic screw over here. So that's what the names of those are.
Cool. Thank you so much.
Pleasure.
So I actually have another question, but I know we're running a little bit late. So if anyone, has other commitments, please don't hesitate to jump off. Just make sure that you fill out the Google form that I placed in the chat, just so that you get credit for attendance. Dr. Mennona, I just had a quick question regarding, well, I know you're going into a joints fellowship, but I was wondering how often would you say that a trauma surgeon would have to, let's say, revise a femoral stem because it's loose in a already existing hip replacement? Let's say you have a fracture, the stem comes loose. Would the trauma surgeon ever go in and revise that stem, or is that solely for the joint surgeon?
That's a great question. The short answer is there's usually a lot of back and forth between the recon guys and the trauma guys. Usually if the stem is loose, then a joint replacement guy will take care of it, or a joint replacement surgeon, I'm sorry, not a joint replacement guy, will take care of it. If the stem is fixed and is amenable to fracture fixation, then the trauma surgeon will take care of it. And that's one of the reasons why I'm doing both, because I'll be able to do both. But if the stem is loose, then it needs like a reconstruction type surgery. If it's stable, then you can fix the fracture. So that's basic answer. But that comes into like when you're going into fellowships, sometimes the question is like, we call them periprosthetic fractures, meaning a fracture around a joint. A lot of times we'll ask like, is that the trauma service or is that the joint service? So it actually varies depending on where you go.
And then that patient of yours that had all of that metal up and down his or her arm, I forget what the reason was. Are you ever worried about their metal ion levels? Because it looked like there was a lot of, implants in that
Metal ion? I would say no. I mean, stainless steel is relatively chemically inert as far as its in vivo interactions. I mean, there's a little bit of a film that forms over it sometimes. Like if you're going back in, like there's like this. It's kind of hard to describe, but there's a connective tissue that kind of forms over it. But the stainless steel itself is pretty corrosion resistant. That's why we use it.
Okay.
Some people use titanium plates, and I think it has a little bit more of an in vivo reaction. But there are times when metal ions are a concern as a result of implants, and that's usually metal on metal arthroplasty.
Yeah, right.
And that can be a concern. Usually the levels come to an equilibrium after like the first year or so, but usually with fracture fixation, it's fine.
Great, thank you.
I have devices related question as well. So if you're doing an implant on someone who's younger and you have to consider like longevity of life,
Mhm.
how do you, I guess, consider like the wear and tear of these implants? And like, would you need to do a replacement? And kind of, I guess, what is the protocol on that? And are there specific materials that are like more resistant to wear and tear?
Sure, that's a great question. So what I will tell you is, like, you look at this guy over here and you're like, wow, it's a lot of hardware. Is it going to stay
Yes.
there? Is it not going to stay there? What I will tell you is that when we put a plate on someone's bone, the plate holds the bone together, but only for a certain amount of time. The plate is a temporary thing. When the
Mhm.
bone heals, the bone itself heals, the fracture heals, and then the bone becomes the weight-bearing structure again, and the plate just sits there. It's kind of like it's a chaperone for a little while, and then it becomes a passive observer. So that's why the plate stays there. It doesn't need to come out, doesn't need to be revised or anything like that. So if you put a plate on someone like that wrist fracture that I showed you, that'll stay forever. The
Mhm.
wrist will heal. The wrist will start to function again like it did. The only thing that's a little complicated is sometimes, like, if you endure trauma again and the plate's already there, the bone may break around the plate instead of breaking where it normally would, because the plate is extra stability. And then sometimes the plate itself breaks, but that's called a periprosthetic fracture again. Now, as far as the durability of implants, yes. So, like, if you do, say someone has like developmental dysplasia of their hip and they're 20 years old and they need a hip replacement, that's a big problem. Not a problem, but it's a complicated pathology. So yes, we will use certain materials that are much more wear resistant. So, like, instead of right now, usually when we do a hip replacement, there's like tantalum metal on the implants itself, and then the head is usually either made of metal, whether it be a nickel titanium type alloy, or it can be oxinium, or it can be ceramics. And then the socket itself is lined by plastic called highly cross-linked polyethylene. And talking about state-of-the-art technology, the plastic itself has undergone a lot of revisions in the last year, or not last year, I'm sorry, the last decade, where, you might have talked to someone 15 years ago and they said, you get a hip replacement, it's got to be revised every 10 years or every 15 years. But now the new technology, the plastic lasts forever almost. And then if you're really, really young, then we'll do hip replacements where it's ceramic on ceramic, and that basically never fails unless it cracks. That's another story. But yeah.
Have you
Yeah,
ever
so-
thought about using, sorry, Jalika.
No, you're fine. Go ahead.
Have you ever thought about using, or have you seen dual mobility implants being used in patients that are younger? Because that's what I was thinking. If you have a
Dual mobility is that's another, like, very advanced thing, but dual mobility is more for stability. So when you do joint replacements, and that's beyond the scope of this talk, but when you do joint replacements, you worry about mobility, and what dual mobility does is it adds a degree of freedom. But most of the time, that's either when you're doing a revision case and they're unstable, or you're doing a joint replacement for a fracture, or there's some other reason that they're unstable. But a dual mobility wouldn't necessarily improve the wear characteristics.
Okay, so it's not like something you use for a primary hip.
Oh no, you can do a dual mobility for a primary hip, but if you do your surgery the right way and use your implants the right way, most of the time you don't need to. If it's a complicated case, you may need to go to a dual mobility, but that's like fellowship level stuff.
Gotcha.
Not nothing that you're going to see for a long time.
All right.
Anything
Well, I mean, there's only 5 of us now. But this was definitely a great talk. So thank you so much. Especially, since you're coming right out of the OR. I know I definitely took a lot out of it, and I hope everyone else did. And yeah, I'm gonna stop recording.